Hello everyone, I'm Dr. Tripat and I'll be discussing with you how to choose the right mask for PAP therapy for treating OSA patient. Now, before I start with that, you must know the history of how the treatment for OSA with CPAP started. So it all started in year 1981 when Colin Sullivan first treated OSA patient with a self-designed CPAP, which you can see over here. And a very important point to note is that the first time when OSA patient was treated in 1981, it was treated with a nasal mask. Okay, and they made a customized nasal mask by making a mold of the patient's face and then making this metallic mask which was fixed with glue to the patient's nose to deliver CPAP therapy. So this point is very important, that the first mask to be used was a nasal mask while treating OSA patient. Then in 1994, almost 15 years later, oronasal mask and full face mask came to be shown as effective for treating obstructive sleep apnea. And you can see that the designs were quite bulky and you needed a lot of straps to fix these masks on to the patient. And definitely these look quite uncomfortable. Now, today in 2021, we have 5 types of masks available to be used during PAP therapy for patients with sleep disorder breathing. We have nasal masks which cover the nose only. We have oronasal masks or full face masks which cover the nose and the mouth. We have nasal pillows which just fit into the nostril. We have total face masks which cover the entire face of the patient, and we have oral masks which fit in the mouth, which are not shown over here with the picture. Now, it is very important to understand that nasal and oronasal masks are very different in delivering the PAP therapy. So basically, this is a diagrammatic representation of patient's airway, which is a collapsible segment. And this is the nose side and this is the trachea side. And this segment can collapse in OSA patient. That is, the upper airway collapses in OSA patients. And when we apply CPAP through a nasal mask, we can open this collapsed airway at a certain pressure. Whereas oronasal mask, when we apply, it applies pressure through the nasal route. It also applies pressure through the oral route, that is through the mouth. And what pressures are achieved when we deliver through mouth, it is something of questionable value. And this is what you need to understand, that when you're delivering PAP therapy to OSA patient, there is a clinical difference in choosing nasal mask versus oronasal mask. Nasal mask and nasal pillows almost have the same mechanism of action by delivering the PAP therapy via nasal route, but oronasal mask is quite different because it delivers the pressure via nasal route and the oral route via mouth to open the collapsible segment. So this is the first study which shows that when we give they compare the size of the upper airway when CPAP was given via nasal mask, via oronasal mask, and via oral mask. This is an endoscopic view of the upper airway, and what you see over here, this white outline, this is the size of the upper airway, and you can see the epiglottis here. And you can very clearly see that upper airway size is maximum when CPAP was given via nasal route as compared to oronasal route, and oral route of CPAP was hardly able to open the airway. So definitely the first lesson is delivery of CPAP via nasal route opens the airway to a larger size as compared to oronasal route. The second lesson that you have to learn is that from this clinical case study, which showed that when we deliver CPAP via oronasal route, the pressures required to open the airway are much higher. Now, there are two sleep reports here. A is first night, B is second night. A report is when CPAP was given via oronasal route. B report is when CPAP was given via nasal route. On the first night, when CPAP was given via oronasal route, you can see that the pressures went up and up quite high, and the pressures went up to 16 centimeter water. But still, the airway was not open, there were desaturations happening, apneas happening. Whereas, and the patient became quite uncomfortable at 16 centimeter water. Patient woke up and was unable to sleep later, and they stopped the study on that night. Whereas on the second night, the same patient was given CPAP via nasal route, and you can very clearly see saturation is quite stable. There are hardly any apneas or hypopneas, and the pressures required to open the airway was 7 centimeter water with the nasal mask. This clearly highlights that pressure required to open the airway with nasal mask is lower as compared to oronasal mask. And this was confirmed with this MRI findings that retropalatal and retroglossal area, they are much better open when CPAP is given via nasal route as compared to oronasal route, where you can see the retropalatal area is almost collapsed. So better opening of the airway results when CPAP is delivered via nasal mask. Similarly, this study again highlighted that, and this also gives an insight into the mechanism why oronasal mask leads to poor opening of the airway. So we need to look at this study. If you see over here, what they have done is on the same night they have delivered CPAP via nasal mask, and they have delivered CPAP via oronasal mask in the second part of the night, and they looked at the airway endoscopically. In the first part, when nasal mask was given at around 6 to 7 centimeter water, airway was fully open. You can clearly see opened airway. But when oronasal mask was given, you can see airway is not fully open, and you can see the epiglottis is pushed back. This clearly highlights that when we put oronasal mask, the lower edge of the oronasal mask, which rests on our chin, pushes the chin backward, which pushes in turn the tongue backwards and leads to poor opening of the airway. Also, the next study highlighted that side effects like nasal congestion, ocular irritation, dry mouth, choking sensation under CPAP, psychological inconvenience were all higher with oronasal mask, which is a center bar, as compared to nasal mask, the first bar, and nasal pillows, the third bar. So side effects are more with oronasal mask as compared to nasal mask or nasal pillows. Also, daily adherence was higher with nasal mask and nasal pillows as compared to oronasal mask. And definitely they repeated the finding that pressure levels required to open the airway are higher with oronasal mask versus nasal and nasal pillows. Also, the type of mask have an effect on the sleep, and over here they compared nasal versus oronasal mask. This blue one is full face mask or oronasal mask. The pink one is the nasal mask, and you can very clearly see the amount of REM sleep is higher with nasal mask as compared to oronasal mask, and number of arousals are lower with nasal mask as compared to oronasal mask, and slow wave sleep is higher with nasal mask as compared to oronasal mask. That means better restorative sleep happens with nasal mask as compared to oronasal mask. So far what you have learned is better opening of the airway happens with nasal mask, lower pressures are required to open the airway with nasal mask, lesser side effects are there with nasal mask, and adherence to treatment is better with nasal mask as compared to oronasal mask. The fifth lesson that you need to learn is residual AHI is lower on nasal mask as compared to oronasal mask. That is, you may have higher AHI values reported if you put your patient on oronasal mask versus nasal mask. And if you look at the leak values, they are almost double with oronasal mask as compared to nasal mask. That means nasal mask leads to lesser leaks as compared to oronasal masks. This study again highlighted that it doesn't matter whether you use auto CPAP or fixed CPAP, leaks are definitely higher with oronasal mask versus nasal mask. And leaks should be a concern, because if leaks happen during CPAP therapy, they can lead to development of central sleep apnea, which can complicate the therapy for OSA patients. Now, this study was done in 2018 from Australia, where they compared nasal mask versus oronasal mask and nasal mask with chin strap, And they replicated all the findings so far, and they found that uh, uh, the nasal mask was having overall higher satisfaction versus oronasal mask. Very interestingly, what they reported is if a patient is mouth breathing and you put chin strap before shifting to oronasal mask, that have a better satisfaction as compared to oronasal mask. More restful sleep was with nasal mask and nasal mask with chin strap as compared to oronasal mask, very clearly highlighting that if your patient is mouth breather and on nasal mask the patient is still mouth breathing, rather than shifting to oronasal mask, better you shift to nasal mask with chin strap. And also what they found is the side effects, all these side effects and the patient preference. Side effects were much lower with nasal mask or nasal mask with chin strap versus oronasal mask. And more patients preferred nasal mask or nasal mask with chin strap over oronasal mask. Also keep in mind, it's very important that if you start titration with nasal mask in the sleep lab, patient should buy nasal mask at home. Do not shift to oronasal mask at home when shifting the therapy to home, because this study showed that if you switch between the masks, the AHI is very poorly controlled when you shift from nasal mask to oronasal mask. So patient should buy the same mask as used for titration in the sleep lab. So in summary, aside from patient preference, there appears to be at least 3 reasons to prefer a nasal mask to a full face mask during PAP therapy. Residual respiratory events, arousals and leaks are greater with full face mask. Full face masks require higher CPAP settings to treat moderate to severe OSA, and switching from nasal to full face mask after CPAP titration increased residual AHI. You can try oronasal mask beside patient preference if nasal mask is not tolerated secondary to nasal congestion and dryness, or persistent mouth leaks happen despite use of chin strap. Now, leads to a very important point, that what can we do if some patients prefer oronasal mask, and what can we do to improve their AHI and pressure requirement. So this was a clinical study done on around 17 patients who preferred oronasal mask in the beginning and had very high residual AHI, as you can see over here. This is the baseline AHI. This is the AHI with oronasal mask delivering CPAP. They had quite high AHI. So what they did is they provide a cervical collar to the patient to use at night along with oronasal CPAP delivery. And you can very clearly see this addition of cervicomandibular support collar almost brought the AHI to zero level. And this patients continue to use CPAP with oronasal mask with addition of cervicomandibular support up to 1 year with excellent adherence. So this is something you can look for your patients who choose oronasal mask, despite your explanations that nasal mask have better clinical outcomes over oronasal mask. There will be certain challenging situations like patient sleeping prone. What to do? Oronasal mask or nasal mask may not be a better option. Nasal pillows may be a better option. Somebody with a mustache and a beard and not willing to shave, nasal pillows may be a better option. Somebody with infection on the nasal bridge, a nasal pillow may be a better option. Somebody without teeth, nasal mask may not be a good option because the lower edge, which rests on the upper lip with the help of teeth, may slip into the mouth. So nasal pillows may be a better option in this patient. So all this summary that I have shared with you, I have put it in a algorithm which we published in 2017 that always start with nasal mask and try to use nasal mask with chin strap before shifting to oronasal mask, and that should be your last resort. If you need, I'll be happy to share this article with you. Before I end my talk, I really want to share with you one study, because in 2007 a study came out saying if you snore chin strap on low on chin strap, no need to use CPAP, can cure your OSA and snoring. But I want to highlight that chin strap alone does not cure snoring, and you can see over here all patients on diagnostic PSG had AHI in the moderate range, whereas chin strap study also had in the moderate range. Optimal CPAP reduced the to less than 5. In mild OSA group, CPAP reduced the AHI, but chin strap could not. Moderate to severe OSA, chin strap could not reduce the AHI, rather it increased, whereas CPAP was able to reduce the AHI as compared to chin strap alone. So chin strap alone is not the solution for treating OSA or treating snoring in your patients. And also, addition of chin strap in mouth breathers before shifting to oronasal mask improves their usage per night. It also decreases their leak per night. It also reduces the AHI during follow-up. So if your patient is on nasal mask and there is mouth leak before you shift to oronasal mask, you better add chin strap for improved clinical outcomes. And your mask refills, that how many times patient changes their mask in the long run of the therapy usage, can be an indicator of how adherent they are to therapy. So this study suggests that the number of mask refills, that is how many times they change their mask, could be used as a measure of PAP adherence where adherence data are otherwise unavailable. And there are some very good designs that have come out which are minimal imprint on the face, and the patient do not feel claustrophobic. They do not rest on the nasal bridge. So some of these masks, you like in this case you can see there is a nasal bridge ulcer, and you cannot use traditional mask which rests on the nasal bridge, but this new design allows to use oronasal mask without affecting the ulcer outcome. So definitely you can make use of these innovative designs to treat your OSA patients. So I stop here and thank you for your attention. And my nutshell is, always start PAP therapy in OSA patients with nasal mask. If they do not have facial hair, if they are not old and they do not have teeth, nasal mask can treat most of your OSA patients. Thank you so much.